Good afternoon, ladies and gentlemen. This is the last session of our conference. This is the complication forum or complication cases. I would like to call my dear co-moderator, Dr. Abdullah Shahab, dear panelists, Dr. Mohanad Ergen, Dr. Abdelmajid Zbedi, and also Dr. Andreas Bombach. Dr. Ala Bidar Abdelmajid, and also Dr. Ahmed Imam. Come, please.
Okay, so I think this is they call it best of the best.
Before we start, please, Dr. Abdullah, we will have 3 trophies for the best 3 cases presented, and there will be a QR code at the end, so you can vote who's the best top 3, so we can give them the reward at the end of this complication.
So we'll go through the cases. We'll have a few minutes after each case for discussion by you guys and the panelists here. So the first speaker is Amro Sayed from Oman. You should have an escape plan when everything goes wrong in complex PCI.
Bismillahirrahmanirrahim. Thank you, dear Chairman. Thank you, the panelists. So my case, you should have an escape plan when everything goes wrong in a complex PCI. Actually, it's 2 cases, 2 similar case scenarios. Case number 1, 73 male patient came with non-STEMI. Echo is about 45%, and this is his angiogram. So left dominant system. The LAD is diffusely diseased from ostium till mid to distal segment, and there is a big diagonal. You can say it like dual LAD, also diffusely diseased, and left BDA is as a distal lesion. The right coronary is small and normal. So the patient was discussed in the heart team meeting, accepted for CBG, but unfortunately the family and the patient declined the surgery. So our initial plan was to do stenting of the left BDA and followed by stenting from the LAD from mid to distal till the left main with provisional stenting. So this is left BDA stented. Our axis was right radial axis, 6 French, XP catheter, 2 BMW wires. Then we stented the LAD from mid to distal. Till now, the procedure was smooth. And while preparing the ostial lesion, so we had a dissection. This is the complication cascade started here. So the first complication was a dissection of the left main extending to the LECX. Remember that this is a left dominant system. So the patient became unstable, hypotensive, bradycardic, intubated, and mechanically ventilated. So immediately, we changed the plan to stent the LECX to left main, and then to do tap from left main to LAD. So stented and put done in the left main, good result. After the recrossing and the pre-dilatation of the ostial LAD, and while trying to pass the stent to the LAD in a tap fashion, the system came out, the stent dislodged, and as you see here, it is dislodged in the left main. So how did we treat the complication? So this is our algorithm for BCI, management of the BCI complications. So we have, during the procedure, 3 Bs: to pray, don't panic, escape plan, and 1 C, call for help. And after the procedure, this is retrospective analysis. So there are 4 different scenarios of stent loss. So either partial stent loss, or complete stent loss with a guide wire in situ, or complete stent loss and guide wire loss, or stent loss in the aorta or peripheral arteries. So this is our scenario, complete stent loss and guide wire loss. This is the algorithm from the Euro PCR. So here, the first step is try to snare the stent. This is what we did. So the escape plan was first to change the axis. We changed it to femoral axis, 7 French. We got a JL catheter, try to get a shot and make sure that there is no bigger problem is ongoing, confirm the patient safety. This is what we did. Then we try to snare the stent. Here, the stent is grasped. Unfortunately, it was entangled in the left main stent, didn't come easily. We had to apply force, and while taking the stent out, part of it is unraveled in the ascending aorta. So this is the third complication. So this is a stent completely deformed. And after that, we started over, better preparation with balloon, NC balloon, bot, tab, then casing. After that, we felt that our left main stent may be longitudinally deformed or not covering from the start the ostium, so we opted to put another short 8x8 stent, followed by bot, and this is the final result. The second case, unfortunately, after 1 week from the first case, young man, multivessel disease, but it is suitable for PCI. I will not go to the details for the sake of time. But what happened here, while we are trying to stent the distal circ, there was a stent here in the proximal part of the OM, high OM. So the stent, again, dislodged in the left main. But here is different scenario because we have complete stent loss, but still the wire in situ. So the algorithm here from the PCR online, so the first step is to try to bust a balloon and take the stent out. If this failed, you may deploy the stent if it is suitable or snare it. So we bust 1.5 balloon, inflated. At the time we are losing the system. Then we took everything out. This was radial 6 French approach. Of course, because of the 6 French and the stent is a little bit distorted, so it stopped at the tip of the sheath. We passed the wire and the 3.5 balloon, deployed the stent in the left main, in the radial artery. So after the complication, you have to sit down in the control room and you review your cases and see what happened, what went wrong. So why did it happen? Because passing a stent through the stent struts or calcified lesion, was it predictable? Yes. Was it avoidable? Yes. If we should have done better preparation with bigger NEC balloon before crossing. Was it manageable in the correct way? Yes, thanks God. And what was the outcome? Both lesions are secured, the stents came out or deployed in the radial. Till now, 24-month follow-up, both patients are symptomatic and doing well. What is the advice for the future? Here, good lesion preparation should have done the job. And don't try to push the stent against any resistance or stent struts. Take-home message, because we had Professor Antonio Colombo here. So quotes from Antonio Colombo, sometimes I feel if I don't get complications, then I am not trying hard enough. You will never practice interventional cardiology without experiencing complication. Learn to solve the problems. Be prepared for all the new ones. Be careful. Avoid to resolve a complication by creating a second problem. And lastly, after a long interval without complications, be ready, one will come.
Thank you very much. So we'll take a comment from one of the panelists, and to you, very brief, please, Dr. Mohamed.
Good, well, very good cases, and thank you for sharing these. Yeah, you summarized how to deal with the lost stent quite well, and one of the important things, and every time you try to take the stent out, if it's not passing, to make sure you inspect it. I have seen people where they took the balloon out or took the stent and thinking it's still there, and it was completely lost in the coronary system. So it's important to check that. And yes, the step you described and also the conclusion are quite important. Be prepared to deal with these cases as always, and a very good save.
Okay. Thanks very much. It's excellent management of the case here. My advice usually to the one who is standing beside me, who is helping me, and my advice to all of us, never, never to put the inflator on the stent while I'm still not in place. Because sometimes, because to avoid air, you just some inflection, and this may lead to loss of the stent wire resistance. So please go with the stent, be free-handed, and then prepare it with the inflator after.
This is exactly what I did after these two cases. I changed my practice not to connect the stent except after passing. Okay.
Go ahead, Doctor. You want to say?
The same, actually. I wanted to ask two questions. Whether the balloon was, whether the stent was prepared in negative, positive, or neutral. The second thing is, what type of stent is it? Is it the same stent in the same both cases?
Yeah. Regarding preparation, before this event, it's the only two stents lost in our lab. Usually we prepare with negative pressure. Regarding the stent, both are with Zions. Word Zions.
Thank you.
Dr. Hani, I will give you, because we are really... Okay,
Yeah,
go ahead.
one word.
Hader, go ahead.
Thank you, but avoid using Judkin left in circumflex. Thanks.
Thank you very much. Thank you. Just reminding you to write down the cases and rate it in your notes. So when we show you the QR code, you can vote these cases.